Hi everyone, it's Jessica Riggleman with my program evaluation addressing overcrowding at Michigan Medicine for MBA611 Business Research Methods. Here are some abbreviations that will be used throughout the presentation. ED Emergency Department, EMTALA, NEDOCS, SSUs, and UMHS, which is been used throughout a lot of the literature reviews that I did because they only recently changed their name to Michigan Medicine. So the problem is a growing number of patients visiting the emergency department. This can be caused by EMTALA, baby boomers, or low acuity patients. EMTALA is the Emergency Medical Treatment and Labor Act. It was passed in 1986. It requires hospitals to evaluate any person that arrives in the ED. Baby boomers, they are growing older, increased need for high complexity, time-sensitive care. And then low acuity patients with minor unscheduled medical issues such as, headaches, chest pains, and it depends on the type of chest pain, cuts, broken arms, things like that. Research questions. Determine what is preventing Michigan Medicine ED patients from being admitted to the hospital for treatment. So we plan to figure out what departments are too full to accept any more patients and why, what can be done to address overcrowding in these departments, and where are the underutilized areas in the hospital, and in what ways would it be cost efficient to utilize these areas for overcrowded hospital departments. The results will be used to form a better understanding of patient needs, gain understanding of which departments are in need of more patient beds, determine a cost-efficient way to utilize underserved areas in the hospitals, and determine if patient education regarding urgent care versus emergency care is needed. As previously stated, low acuity patients come in and it's something that they could be seen, it's very minor, they could have been seen at urgent care for shots, stitches, things like that. So our scope is to focus on the emergency room patients and the care they are seeking while addressing those departments that are admitting patients to the hospital but do not have a bed available for these patients. Like the CVC, the Cardiovascular Center, they get a lot of patients and then they don't have enough room. And then we will use the number of open beds available in the hospital to determine if the departments can take on additional patients. So our literature review uncovered a few things. First, that it's an ongoing issue. Emergency room crowding has been an ongoing issue for many years with patients either waiting to be admitted to the hospital for further care or waiting to be seen. Some ways that have been suggested to alleviate this issue is short stay units, resuscitation rooms, and increased staffing. I will cover short stay units and increased staffing. Resuscitation rooms are rooms where the person comes in with chest pains or problems with breathing, and instead of being sent to the waiting room where they could go into cardiac arrest, they are put in these resuscitation rooms. So should cardiac arrest happen, they are being served quicker to repair whatever the issues that cause that cardiac arrest. Databases show ED crowding on a national level, but not being utilized to alleviate the issue, which means that every emergency department has access to these databases, and they're not taking the information that these databases contain to figure out a way to alleviate the issue of patient crowding. The NEDOCS score was overestimated when it came to crowding when compared to that of perception of healthcare professionals. So NEDOCS has a lower score of what they determine overcrowding is, while healthcare professionals is a perception, and they determine that, based on their stance on whether they think something is crowded, whether they think the emergency room is crowded, then they evaluate that way. So first is EMTALA, And it was a federal law passed in 1986 that requires anyone arriving at the emergency room must be seen regardless of insurance status or ability to pay. It defines an emergency as a condition manifesting itself for acute symptoms for sufficient severity, including severe pain, such that the absence of immediate medical attention could reasonably be expected to result in placing the individual's health or the health of an unborn child in serious jeopardy. It's an unfunded mandate that's causing an ongoing strain on emergency room personnel. So unlike Medicaid, this isn't federally funded. It's a federal law, but it's not federally funded. So there's no reimbursement for hospitals to receive when a patient who cannot pay or has no insurance comes to the hospital. So they're using hospital resources, but there's no immediate way for them to pay it, and they're not required to based on this law. Prevents emergency departments from transferring uninsured or Medicaid patients to other hospitals for care. Basically, the patient must be evaluated, and the hospital must be determined that they cannot treat the patient to the best of their ability before a transfer can happen. They cannot transfer them just because they don't have money or insurance. Violation of this mandate can be subjected to a penalty which can include, but not limited to, termination of the hospital's Medicare provider agreement, fines of up to $50,000, or a civil suit for personal injury. So if something happens to a family member that presented at a hospital, the patient came to the hospital and they were turned away, then the family and something happened, whether they got sick or they died, the family has the right to sue. Additional staff was presented as an idea, and hospitals tend to add more junior residents during peak hours, which causes an increase in patient wait times. Junior residents a patient has more steps when they're seen by a junior resident. So when they are taken back for observation, the junior resident sees them first, which then he reports to the senior resident and the attending what is going on. And then the patient is seen by the senior resident and then finally the attending to address any issues, make decisions regarding their care. If the junior resident believes that a CT scan has to happen, the attending physician has to sign off on it. Additional senior staff could alleviate patient wait times. Senior residents and board-certified physicians and nurses aren't required to do this checklist of checking with other people. They can make the decision and go forward. It is also believed that the patient volume in the emergency department can be somewhat predictable. So in order to schedule additional staff during the peak times, then they can use that information, which the highest is usually during the evening, during the week, primarily Monday, Tuesdays, and Sundays. So they can use that for scheduling of when they would like more senior staff on the schedule. Another suggestion was more bed, less wait. Short stay unit are areas that house patients that require additional observation but have not been fully admitted to the hospital. So someone who comes in with chest pains, they aren't showing signs of any distress, but they're not finding out what is wrong. This will put them in a room where they can be observed for 24 to 48 hours to see if they can figure out what is going on before they finally discharge them or admit them into the hospital. This would free up beds in the emergency department for patients waiting to be seen, because this would be a separate unit that wouldn't have beds in the emergency department. This would be a different unit, probably, near the emergency room, but not in the emergency room. 30 beds are currently dedicated in the emergency department at UMHS for admitted patients that have not been assigned a bed within the admitted department. So the department says, yes, we're going to admit them. We don't have a bed for them. So then they are in the emergency room waiting for a bed. And then short stay units would be roughly 16 beds, and that would move patients that need to be further observed out of an emergency room bed into the short stay unit, which would decrease the amount of patient time waiting to be seen. Program evaluation is, my research approach is program evaluation, evaluating past methods to determine which of these methods were unsuccessful, determining which methods would be successful and what is needed to make them successful, determining how to address the growing patient population and where resources are needed, using space surveys to learn information on patient areas within the hospital. Space surveys is a tool that the university uses to determine room size, room features, what the current use is, if there are beds, are they being utilized, current occupants. However, current occupants only applies to current university staff, not patients. That's why we would need to find out the number of beds. And then conducting interviews with staff to learn how overcrowding has been previously addressed, and anonymous online surveys for staff to learn the perspective on ED crowding. They would be anonymous, so we could keep their information, so there isn't any repercussions for anything negative said. And if they have any input or any thoughts on what is being done, then they can do so, and this information can be presented to the administrative team at the hospital. So here's the online survey for the Michigan Medicine Staff Climate Survey. The purpose of this survey is to determine employee perception on patient overcrowding in the emergency department at Michigan Medicine. The questions are, what's your position? How long have you been there? Have you ever worked a longer shift due to the number of patients in the emergency room? Rarely, never, sometimes, often, always. That would mean always would be that every shift they come in, they are required to stay longer. How often do you feel the emergency room is crowded? Never, rarely, sometimes, often, always. Like I said, if they say always, that means every shift that they work. Do you believe patient care is suffering due to the overcrowding? Do you feel the university is doing enough to address overcrowding in the emergency department? Do you have any suggestions that you would like to go to address overcrowding? So sometimes people that are in it tend to have a better perspective on what can be done to help. And so that is the area where they're allowed to give some opinions, and hopefully that will be used by the administrative staff. Here are interview questions for the Michigan Medicine administrators. Their position, how long have they worked here? And I ask how long because sometimes, the longer you work somewhere, the better of an idea you have how things are being run, as opposed to when you're there for a short amount of time, you haven't really gotten into the thick of it. Are they aware of any overcrowding issues? What is the university doing? Do you feel patient care is suffering? What plans are in place to address overcrowding in the immediate future? Is there a 5-year plan in place? And what areas do you hope to implement to address staff and patient concerns? And here are my references. And that's everything. So thank you for your time. Feel free to let me know if you have any questions. Thanks. Bye, everyone.